I have been asked to be a little quicker with my presentation, and I will focus on what my second part of the presentation was asked to be, and that is some case presentations. So you have heard already a lot about the indications of biological valve procedures today morning, and I just want to reinforce that in terms of guidelines, if you're less than 60 years of age, you should have a mechanical valve procedure implanted. However, as we said early on, there are some patients who have a strong desire not to have a mechanical valve, and of course, the women thinking about family, that is a particular issue. We have discussed this here today morning. There are advantages with biological valves, advantages with mechanical valves, and of course it is down to age. But there's no question that in the age group between 50 and 60, there is more of an ask for biological valves nowadays. We know that we have quite good valves available here, the outcome data from the Paramount, which you have seen today morning. For the ones who were not here, if you're below 60 years of age, at 18 years after the operation and 50% of the patients, you still have freedom from structural valve degeneration, and this is based on echo data, so that is quite good outcomes. If you have aortic disease at the same time, which is not uncommon in this patient group of younger patients with aortic valve disease, aortic valve stenosis, you can do the you can replace the aortic root at the same time. And again, 15-year outcomes, and less than 60 years aged patient, 70% freedom from structural valve degeneration. However, there's always a need to improve further. And as we have heard today morning, there is discussion about mechanical and biological valves, and there are, of course, also people who are very questionable about biological valves, and that's the reason why there was a focus on developing new devices. We have seen the sutureless devices. We had a long presentation on this today morning. I never have jumped on those, and the reason is that from my point of view, there's not much of a difference in terms of ischemic time benefit achieved. It's a new type of valve, at least the Percival. It's a new design. New designs always have a high risk that they fail, and that is just how history tells us. The Intuity is based on the Paramount platform. That is good, but on the other hand, you have seen you have a large proportion of the valve sitting inside the annulus, and I don't like to put something in the annulus necessarily. Sometimes it's good to put something in the annulus so that you have a better flow, but you do not necessarily benefit from that. That's the reason why I never warmed up with the sutureless valves, but what I warmed up was this valve, and the reason is that this takes all the advantage of the past, and one thing has changed, and that is the way the biological valve and the biological material is treated, and that may make a difference. And so from my point of view, as surgeons, we have the responsibility to present the best outcome in terms of valve hemodynamics, no pacemakers, no power leakage. If we do not keep that standard as high as possible, then there will be no question there will be an overrun of TAVIs in the future of the surgical field. So the higher we keep the standard for surgery, the more of a defense mechanism we have to actually deal with TAVI procedure in the future. And that's the reason why I think one can bring all kind of new innovation in there. But if you have more power leakage of a problem, if you have more pacemaker of a problem than you have as conventional surgery, you need to be careful that you do not shovel your own grave. Nevertheless, coming back to the Inspiris valve, the thing which has been changed on the biological material is that it is still bovine pericardium, but the free aldehyde bridges, which are, have been there in the past in the Magna, which are actually responsible for the early calcification of the valve and degeneration of the valve, they have been blocked. And the valve comes in a dry packaging now, and that is to keep them blocked until the valve is implanted. And what we know from implantation in sheep is that the amount of calcification on the left has been reduced in sheep, which is a good animal model, as we know from the past, by 2/3. What you can see on the right is that the reduction in calcification has also resulted in lower gradients, but the problem is the sheep is only the sheep. And the Vesilia tissue has been used on the original Paramount Magna platform in this COMMENCE trial, but the outcome data is only for the last 2 years. But knowing that the valve has not been changed in structure, knowing that the only thing is the biological material and the treatment, I think I have more confidence in this valve than in some other valves in terms of long-term prognosis. The one thing you can also see from the COMMENCE trial here is you should not necessarily implant small valves in big patients. The hemodynamics are very good. If it comes to 23 and bigger, it's single-figure mean gradients, but below that you have double-figure mean gradients, which from my point of view is difficult to have because you need to produce the gold standard for aortic valve treatment, and that needs to answer what you can achieve with TAVI and other treatment options. I said the structure of the valve frame is completely the same. It's not completely the same. The one thing is you can now see the valve size from the design, and you also have a wing which, if you put a certain amount of force on the mechanical stent, then it will enlarge a little bit further, facilitating maybe valve-and-valve procedures in the future. The first patient I treated with this device is a 26-year-old young woman. She was known to have bicuspid aortic valve disease since the age of 18, had only moderate symptoms of NUHA 1 to 2, but she then wanted to start her family, had a repeat echo, and that showed severe free AR with a mid-sinus diameter of 30 millimeters to a junction of 26 millimeters. And as a result, she was referred and discussed at King's because it was not seen to be safe for her to have and to become pregnant without treatment. So I discussed with her, as I usually always do in these patients, the option of aortic valve repair with preservation of the bicuspid aortic valves, something I would not do in all patients, but in young patients like her, I think it is an option you should discuss. I discussed the WASP procedure. I'm not a big fan of the WASP procedure because I have operated on so many patients with WASPs in the past where actually not the aortic valve had failed, but the homograft has failed. I've operated on quite a number of patients where WASPs were done in aortic root dilatation. That is not working well. So I personally perform WASPs if that is needed and has been needed in the past in adolescent patient, but not in this age group. And I discussed with her the biological aortic valve replacement using the INSPIRIS valve. She had the operation to a limited upper sternotomy, as it should be routine from my point of view. She showed thickened and severe calcification on both cusps. In these patients, I do not consider to preserve the bicuspid valve usually because the outcomes are not very good and questionable from my point of view. But instead, I implanted a 25 millimeter INSPIRIS valve. As you can see, the ischemic time was 37 minutes. The operation time was 75 minutes. And she had a normal postoperative course, as you would expect in this age. No AR, mean transvagal gradient after surgery, 6 millimeters mercury. And she went home on day 5 after surgery. So she's now waiting to become pregnant. And we will see what happens with the valve. The good thing is she's so young that if the valve fails, we will see it relatively early. So that is something which I think, from my point of view, is something quite good. So you get an early response about a device. And so she was the first patient treated with the INSPIRIS valve, I think, in April last year. The second patient is the first native aortic root replacement I've done with the INSPIRIS just recently, 2 months ago. He is a 28-year-old gentleman, marathon runner, very sportive, very active, was known to have bicuspid aortic valve disease. Shortness of breath on exercise didn't really count in him because, I mean, he got shortness of breath when he was at the end of his marathon. But nevertheless, he then had repeat echoes, had severe AR, a dilating left ventricle now, ejection fraction 55%. He had mid-sinus diameter of 42 millimeters, signed to a junction of 46 millimeters. So again, I discussed the same like before, aortic valve preservation, root repair, WASP procedure, biological AVR. Intraoperatively, he had a unicuspid aortic valve, and from my point of view, I didn't expect it to have the best long-term prognosis. That's the reason why I replaced. He, as the same like the first patient, didn't want the root because he didn't want to have a two-valve problem instead of a one-valve problem. So they both opted out of the WASP procedure option beforehand. So in him, I replaced the valve using I thought I replaced it with a 29 millimeter, but here it says 27 millimeter. Must have been a 27 millimeter Inspiris valve. Placed it into a 30 millimeter vascular prosthesis, reimplanted coronary arteries, and his operation took 121 minutes. Ischemic time was 67 minutes. He had a normal postoperative course, again, as these young patients do. And his ejection fraction was 50% after surgery. Left ventricle was interestingly already smaller. Transvalvular gradient was 2 millimeters mercury in him, and he went home on day 5 after surgery. But I don't see the Inspiris only as a good substitute for native first-time surgery and native treatment, but it is something which I think is also quite helpful in patients where you would like to implant a biological valve earlier in terms of age than others. For example, what I mean by that is I do not like so much to implant mechanical valves into endocarditic patients. Endocarditis, the last mechanical valve I implanted into an endocarditis patient, that was something like around 10 years ago, a young gentleman who stroked 5 days later with a bleeding into his brain. And that was, although he did not have any stroke or cerebral embolization history before. And so that's, from my point of view, one of the patients groups where actually one benefits maybe from a new, more innovative device. And the other one reason is, as I said earlier on, with the root dilatation in young patients. This here is a 43-year-old gentleman who had a similar story, maybe like the one I just showed to you, but he had it already in 2002 when he had a replacement of his aortic root and ascending aorta using a 29 millimeter Valsalva stentless prosthesis. Actually, it's quite interesting when one looks at the long-term outcome of the Valsalva graft. That's the first generation of heart valve, but nevertheless, it was implanted into him because he didn't want to have warfarin treatment, not in my institution, but somewhere else. He was on follow-up, and then 15 years later collapsed while he was in front of King's College Hospital and fell off his bike. And that was the way he came to the A&E department at King's. And at that time, he had free flow AR, a left ventricular ejection fraction of 20%, and severe MR. And as you can see on the right side, he also had a dilated ascending aorta sitting directly behind the sternum. And he still, although the valve has failed, although he was very close to actually die from his valve problem, he wanted to have a biological valve solution again. So, and I discussed with him stentless valve and the Inspiris, but he bought into the Inspiris idea more than into the other idea. And so I operated on him through a right axial cannulation, resected 2 centimeters of his prosthesis and reduced the size of the vascular prosthesis. But nevertheless, then also explanted the stentless valve out of the prosthesis and implanted this Inspiris valve at 29 millimeter into the prosthesis. Repaired the mitral valve with the 2 millimeter Cosgrove band, occluded the left atrial appendix, and his ischemic time was a little bit longer, 81 minutes. But again, on the valve, he had a good outcome. The left ventricular ejection fraction improved already before discharge, 30%. His gradient was interestingly relatively high, 12 millimeters mercury. Usually I say double figures should not be there, but he had a 29 millimeter valve prosthesis, and he was a small person. I don't know why his mean gradient was higher, but he went home 5 days after surgery, and he was doing fine. And the last patient I have here is a 38-year-old gentleman. He is a patient with endocarditis. He had aortic valve replacement using a carbamatics valve 2 years before I saw him. And when he was admitted to King's, he had signs of prostatic endocarditis and perforation of his enteromitral leaflet. He had no risk of embolization, was hemodynamically stable. That's the reason why we took blood cultures first and treated him with antibiotics. But nevertheless, he then, after 5 days, had an operation through a full sternotomy, explantation of the aortic valve prosthesis, had a mitral valve repair, and the PFO closure. And in him, the aortic valve was replaced using a 27 millimeter valve prosthesis. Ischemic time, 74 minutes. Gradients, again, 6 millimeters mercury, so a good result on the valve. But he needed to stay, obviously, in hospital for longer. He stayed for 4 weeks to complete his antibiotic treatment, but was fine afterwards. So in total, I have done 15 patient with the Inspiris valve now because I don't use it in many patients, only if they are really below the age of 55 usually. Mean age, as you can see, 42 years of age, quite a significant number of bicuspid and unicuspid valves. We use in 4 patients, endocarditis in 2 patients, and in a number of patients combined procedures. But for the isolated AVR, the ischemic time is 44 minutes, and 3-day mortality, it doesn't exist because they are all relatively young. You don't expect that to happen. And mean gradient is 7 millimeters mercury, and they go home 6 days after surgery mean. If they don't have endocarditis, then they, of course, stay longer. Therefore, I would like to conclude that in aortic regurgitation, the aim should be to repair or preserve the aortic valve. In patients in whom the aortic valve needs to be replaced, there is no ideal substitute, and the Inspiris offers potentially improved durability compared to the well-established pair-mount bioprosthesis, and also allows for valve-in-valve procedures in the future. Thank you much for your attention.